Okay, so this is kind of a follow-up. Um, Obviously, I have some questions on final exam. Um, Kind of hoping to get to it yesterday, and all sorts of stuff happened. But so I'm here now looking at. I'm going to look at a couple websites and just kind of go through what's important. Um, Anatomy will be a big part of the test, and so that's what we'll look at right now. And this is not going to be a total review of everything anatomy. Okay, so you should be looking at the screen. This is Ultrasoundpedia, by the way. Very good resource. And let's just kind of go through. Segments, absolutely. No, the segments. Caudate lobe number 1, medial left lobe, and remember, I don't like this picture entirely because the left lobe really crosses the midline and is more just a little bit farther over, but that's okay. That is okay. We go from 1, the caudate lobe. We go all the way out to the tip is 2 and 3, and of course, and I'm not going to do this to you because it's too difficult, but because even I have a hard time looking at an ultrasound image, and I have to really think about the fact that I'm looking at it upside down. So oftentimes when we're in transverse, looking at 2 and 3, 3 is on top of 2 because you're looking at it upside down. But like I said, I'm not going to hit you with that particular confusion for this test, but this guy, yeah, absolutely. He is all on board. Know that. And use your, your right hand as a fist. And I don't care if you write it out on your fist, which is 1, 2, 3, 4. That is fine by me. Well, that's just a very typical picture. So one of the things, look at how pretty that is. And they're right. That's actually a good point. What is? If I could put an arrow to this, and you better say diaphragm or dome, but diaphragm is probably more correct. They're actually both correct. Of course, that's the right kidney. We know that. And the difference between portal veins and hepatic veins, those are not obvious. We're not seeing a lot of either of these veins, but we should be able to see some differences there. Also, echogenicity between the liver and the kidney parenchyma up here, like right here on the kidney. What does that look like? Absolutely. Which hepatic vein is coming out in this direction? If you don't know that, well, you really should by now. Which is this? This one's got 2 branches, but it's still considered 1. There's, on most people, JP excluded, there are 3 major branches. There could be multiple other branches, but there's 3 majors. Where does the left lobe end on this patient? Where does it end? It ends along this line. So this, where my arrow is, hopefully you can see that. Let's actually get a better, more annotate. Spotlight. Okay. Hopefully, you know that this is left lobe, because what's the difference between left and right lobes, or what separates the two? The main lobar fissure. What's in the main lobar fissure? The middle hepatic vein. What else is in the main lobar fissure? You guys have to know that one too. Okay, here, this is a great image. We actually have, okay, so on this one, we could be asking, I could say, where's the dome of the liver, or where's the diaphragm? Where's the IVC on this picture? Well, it's right here. That's the IVC. Where's the umbilical segment of the left portal vein? Right here. See that? Well, this is still left portal vein. And then here, you see how that's different? That's actually the right portal vein. What we can't see in this picture, middle portal, main portal vein. We cannot see in this picture because it is a three-legged stool and that leg is out of the picture. Here, so, you know, we look at, what is this? Well, I guess we all know what this is now. We've got everything's lit up here. But boy, on this patient, this is a child, most likely, or just perhaps it's this patient right here, which looks pretty darn thin. We are seeing actually both kidneys, which is pretty good. Typically on children, we could do that, not so much on adults. We see a pancreas. We see, ooh, what's the little hole right there? It's not labeled. What is that? Which one is that, guys? Aorta, SMA is in there. See, now they're calling it portal vein. Is that accurate? Well, yes. Is there 3 other things you can call it? Yes. I'm going to leave it up to you. You got to know what those 3 other things. One thing comes from this way. One thing comes from inferior. One thing is just a name that we give to vessels that come together. Okay, so those are types of things that you need to know. This is all just anatomy so far. So hepatopedal flow. That's what's the opposite of hepatopedal flow? And so yeah, that looks good. This is not too much as far as variability, phasicity. Is there cardiac cardiac phasicity? Why can't I think of the right way to say that? Anyway. Oh, how cool it does. A little wackadoo. We've seen this picture before. Left, middle, right hepatic veins separating out the segments. Like I said, I'm not going to get you on the segments on the ultrasound image. That takes a lot of practice. Is this the right flow for the hepatic veins? Is this what we want to see? Let's see how much I can get out of pancreas normal. Let's see other. Pancreas normal. So what else are we seeing here? Now this time we see, oh, all right, I told you, CVD. What was that other one? What was that other dot on top? Did you guys figure that one out? Of course, that's the pancreas. Guys, a lot of you are very concerned about imaging the pancreas. You should be. It's very difficult. Don't worry. If you don't feel like you're seeing it beautifully, don't worry. That's what the months of practice are for. Okay, let's move on. Oh, and of course we've got to see. Now this person, this person's got a very long left lobe of the liver, long in the inferior superior direction. And so their pancreas is kind of flattened out, and they're thin. So the pancreas is kind of flattened out here. It looks, everyone's pancreas in sagittal looks really different. There's also very different echogenicities, right? Because if you're older, it's fatty. If you're fat, it's fatty. So what else can we look at? Well, here we go. Fatty infiltration of the pancreas with focal sparing of the uncinate process. Oh, that's awesome. I told you guys about this, didn't I? That the uncinate process can have a different echogenicity than the rest of the head, body, and tail. That's kind of cool. It's fatty infiltration. We know it's fatty infiltration because look at it compared to the liver up here. Much brighter than the liver. Yeah, you see no mass effect or compression of the CVD or progress. Okay, so same patient. Yeah, there's no mass effect on the CVD. It's nothing's being squeezed out or anything. Beautiful. What vessel is this? Guys, you are struggling. you are struggling with this, and I am going to test you on this, and I don't care. Well, of course I care, but I don't. No, I do. I do care. But what vessel is this, guys? It's one of the three that I mentioned that make up this circular. There's one vessel coming up from this direction. This is a transverse picture. Here's that other vessel. What is it? You have to know that, guys. Oh my God. The pancreas before water and after 2 glasses of water. So they're being sneaky. So can we see the pancreas? I mean, I guess, well, it's a very different picture overall. I really can't see in that first picture, I can't see it. But of course, what they've done is here's liver, here's stomach with water in it, and now they're getting a picture. It's not apples to oranges because, oh, and pancreas erect. That's something else we could try, but that's just more lab technique. We don't need to know that. Okay, let's come back up. What else? What else is this website going to give me before it kicks me out? We're just going over normals for now. Beautiful. Well, yeah, neck fundus, body. Okay, so they've given this away. It's a Frisian cap up there. What is it? What is it called when there's a fold down here? This is crazy. There's a crazy folded. Okay, let's keep moving. There's nothing else. Not enough pictures in that one. Let's look at gallbladder pathology, because we will need to know some pathology. And I got kicked out. Okay. I actually am a member, but my password's at work. All right. I am talking to a Zoom meeting, hopefully. In fact, now you got me thinking, am I actually recording? Yes. You need to talk to me? No. Okay. Okay, let's just go through images. I wish I could make this bigger. Okay, well, stone. How do we know it's a stone and not a fungal ball? Shadowing. All right, gotta have shadowing. A stone this large, if it has to have shadowing. If it doesn't, it's not a stone. I got caught up on that once. What else can we say about this gallbladder? There's got to be some kind of fold in it, some significant fold. What else can we say? That's all gallbladder wall. Thickened wall. Let's see. How do let's just do this. Okay, what's going on with this gallbladder? Looks to me like regular old polyps. Multiple septations. Sludge ball, yummy. Let's see, gallbladder pathology. Is there a pathology in this gallbladder? Let's look. Wall. See, here you can't, on this person, can't look at the posterior wall. There's too much sound going through. So we have to look up here. That wall looks pretty good. I bet if we measured it, it's fine. There's a fold in the neck here. That's completely normal. I don't see anything wrong with this gallbladder. Let's just keep going. What the heck? I can't even describe this. Is what? All right, now they got me. Now they got me. I got to go look at this. Miscellaneous gallbladder, septated gallbladder with gallstone. Was there a stone in there? Did I miss it? Okay, well. I guess. I mean, there's definitely some kind of shadow being produced here, but gosh, okay. If you, this is ultrasoundcases.info. I don't like this site. Dr. Taco. Anyone named Dr. Taco is questionable to me. So let's let's get out of that. Okay, let me zoom to this a little faster. Thickened wall. Sludge. Don't look at this. Don't look at this. What is this? Comet tail reflections coming, or comet tail artifact coming off the gallbladder. Here again, comet tail artifact. What causes those? I guess we know now that's adenomyomatosis, but what actually is adenomyomatosis, and is it dangerous? There's different forms of adenomyomatosis. There's more of a diffuse form, which I find more often. And then look at this. Is this like a band across the middle of this gallbladder? So look at your different forms of adenomyomatosis. Okay, let's get out of gallbladder. Let's talk about ultrasound gallbladder. Ultrasound, biliary. Yes. Portal vein, the guys, always. You're going to find a portal vein with a common bile duct and a hepatic artery. There are some variations. You could have two hepatic arteries. There can be a little bit of confusion going in, but once it's in the liver, this is always going to be found inside of the liver. Outside the liver can be a little bit funny just because of different arterial possibilities. Let's see. What else? What's going on? This is a gall. Okay, good. Doesn't say it. What's going on? What looks different about this common bile duct versus? Oh, this is beautiful. Look at that common bile duct. Actually, we're going to go back to that picture. There's some stuff going on. What's going on? Look at the walls. These are thickened walls on that gallbladder. That is of concern. So actually, let's look at the radiology assistant. Oh yeah, now this one I do like this. Ultrasound, one of the earliest features of acid cholangitis, but it's primary sclerosing cholangitis. Of course, dopey dope. One of the earliest features of primary sclerosing cholangitis in sonography is thickening of the wall. You can read about this later. This is not a total review. We cannot possibly do that. Okay. Well, ooh, I wanted to go back to this picture, right? So, gosh, beautiful. Beautiful. In a pretty normal looking gallbladder, right? Or is that wall? You know what? I guess I have to have a second look. This looks like a thickened wall, but everything else is so incredibly normal. Maybe I'm making things up on this one, but I definitely feel like the wall goes from here to, oh God, what did I do? There to there. Okay. Moving right along. Oh, great. The, what's it called? The inchworm sign? I used to call it the angry eyebrow because I didn't know it was called the inchworm sign, but that is always nice to see. The hepatic artery, 9 times out of 10, goes underneath the duct. Now they said bile duct, and they were smart because actually this is common hepatic duct, and common bile duct probably starts right about here, but this is a great way to know where you are. Let's see. Common bile duct, yeah. Right hepatic duct, left hepatic duct. Oh wow, okay. Boy, this person, yes, myeloid leukemia. That's a mess. This person not look at how thick the walls are and a thickened common bile duct, but we don't need to look at that. It's okay. And intrahepatic ductal dilatation. When there are too many, now this one's a little more obvious, if there's something going on. Oh, double barrel sign. One of these is a portal vein, one of these is, and this is inside the liver parenchyma. Something's going wrong here. The monkey puzzle. Never heard of that one before. Okay. Anyway, I remember there's things like Carelli's disease with the gallbladder. You know, of course, in the gallbladder we have cholelithiasis, and the gall ducts and the bile ducts is choledocholithiasis. Ultrasound. Oh, let's just look kidney. Oh, let's put vascular. Let's get that in there. So, all right, let's look at this beautiful kidney here. You know, do we know what this vessel is? Right here on top of it, or this one, or this one, or this one. All right. I am pointing to vessels, and actually the blue ones are the same. They're just blue because they're diving away from the transducer. But look at that. They're on either side of a pyramid. What vessel are those? What vessels are these? Inside of the collecting system, branching. All right. What vessels are those? What else is going on with this kidney? Or this person? What's right there? Is it supposed to be anechoic around the outside of this kidney? Well, obviously it's anechoic there, it's outside the picture, but here that's anechoic. So this person has some ascites. Well, it's a renal transplant, so perhaps it could be blood ascites or whatever. And the last homework, I had a question about ascites versus free fluid, and when it comes to the abdomen, this is free fluid. It's also ascites. Free fluid is generally, we generally talk, when it comes to the abdomen, if it's a tiny amount of fluid, we might say free fluid. If it's a larger amount of fluid, we call it ascites. So on I think on my homework, I said small ascites, and I probably should have said just free fluid. would have been more correct. All right. Gosh, what does, there we go. What, gosh, what characteristic of this waveform does this, first of all, does this look like a normal renal waveform? Well, let's think about this. Well, anyway, I'm trying to find LI left. I don't know. Anyway, is this normal? Well, okay. Is there tardus parvus? No. I have a very fast upstroke. What's the RI? 0.68. Yeah, that's normal. You don't have to memorize the R. Well, you should. There's a few RIs that you do need to memorize, but as far as this goes, you could look at this and know that the resistive index is correct, because this is the correct amount of resistance just by looking at it, just by the feel of it. What else does this waveform have that tells us this is a normal waveform? It's got that early systolic peak. Now that early systolic peak can actually be less than the late systolic peak, but in this person it's higher. So there's an ESP on that. Now this one makes gonna make you think, but look at that. The RI is 0.63. And here's a place where the early systolic peak is actually less than the late systolic peak. But overall, at first glance, I'm like, oh, is this a little bit of tardus parvus? Well, actually, no. Because of this early systolic peak, it actually is a sharp upstroke, and then there's like a continued systole, and then it goes in diastole. But that's a hard one. I probably wouldn't sneak that one in on you, because even I had to look at that. Because when you compare that to, let's say, this one's got sharp, and not really, I wouldn't call it rounded, but it kind of has that same look to it. All right, enough, Kurt. What else about the kidney? Oh, what about ultrasound kidney, cortical measurement. All right, great example of not correct. So free of cortical thickness. Okay, well, here, so, oh, no, they're correct. Okay, good. So length, by the way, guys, good length on this kidney. Cortex, look at that. It goes from M, I'm assuming it stands for medulla. All right, so medulla, there's a pyramid here, that's the medulla. The cortex is from here to here. So when you want a cortex measurement, it's only from the outside to the base of the pyramid. A lot of times it's hard to see. This person, oh no, they have an AB. Okay, these guys are all doing it correct. Good to see. All right, so cortical thickness. Whoops. Ultrasound kidney. Stones. Let's look at stones. All right, guys. So, all right. You can see why I consider kidneys difficult. Doesn't this look like so many other echogenicities that we've already seen in all of our kidneys? But this one shadows. Dang. I mean, look at that. Look at that. How hard is that to even see in the first place? And then we have to find the shadow. Man, I feel bad for you guys going out there in the field. Yeah. Total fake. fake picture. Your fake news. All right. What about Twinkle? You guys remember Twinkle Artifact? No. Twinkle Artifact, guys. Well, here's a Twinkle Artifact in a bladder, which is awesome. So it's a color artifact, guys. You have to know about this. Whenever you see a suspected stone, this is one of the things you do. You want to optimize your color to see this, but those Twinkle artifacts are really helpful. Once you have that, then you know for sure what you're looking at, of course. Oh, look at that. UVJ obstruction, right? Vesicle, ureteral vesicle junction obstruction, UVJ. V is in vaca. Vaca. What Spanish say is confusing between V and B. Anyway, I don't know. Kidney. All right. What else? What else do we need to know, guys? What else did we learn this semester? God, so much. Oh gosh. Well, I mean, it wasn't just abdomen, was it? Oh no. Oh no. Gosh, we have thyroid, and oh, these are awesome. Inspissated colloid. So you see this a lot. It's a colloid cyst. It's a thick jelly cyst. And for some reason, a lot of times towards the middle, it gets a little hardened and creates that kind of a echo structure. But gosh, thyroid. I got to think about how much I'm going to get you guys on the thyroid. Definitely need to know things like, you know, the lobes, isthmus, this lobe, that lobe. You know, at first glance, does this person have a normal thyroid? Well, even if you don't see it over here, you should definitely see that this isthmus is gigantic, and we have an increase in color. So this person has some kind of thyroiditis, perhaps Hashimoto's, or perhaps a Graves' disease. Let me, you know what, let's get out of thyroid. I'm not 100% sure how much we're going to do thyroid. Testicular thyroid. Okay, let me stop right there. Okay. Well, I guess the next step, let's see, it's only 8:30. Let me create the final exams, go back, grab other finals, use the finals that I have. Oh, I gotta be careful using the other finals because those are other books, but I do have access to all of the questions. Oh yeah, I gotta totally rebuild it. Let's start doing that right now. So I'm gonna rebuild, I'm gonna build these finals out. Tomorrow I'll have a better, tomorrow we'll go through scenarios, possible questions, possible subjects that you will need to know. But not that anything I talked about today is irrelevant, but it was a little more of a free-for-all.